we are going to discuss about a very, very interesting group of cases, which is a presentation of hypokalemia, which is quite common in pediatric practice, but often can have a lot of confusing areas in that regards. So we are all well aware that the most common causes of hypokalemia in pediatric practice are either gastroenteritis, in which this is usually associated with acidosis, or renal tubular acidosis in a more chronic sense, again associated with acidosis. Today, we are going to focus about a very specific niche of patients who have hypokalemic alkalosis and normal blood pressure. And as we discussed earlier in the last grand round couple of months ago, we talked about hypokalemic alkalosis with hypertension, in which we talked about aspirin mineralocorticoid excess, 11-hydroxylase deficiency, 17-hydroxylase deficiency. So today our focus would be individuals who come to us with hypokalemia, alkalosis, and have a normal blood pressure. 2-year-old boy with failure to thrive who presented with a weight of only 8 kgs, as we can see, and had a height which was compromised and had hypokalemia. Now, the most important approach in hypokalemia, of course, is to see whether there is a acidosis or alkalosis. So this individual had metabolic alkalosis. So this excludes a lower GI loss or a possibility of a RTA from that perspective. The next step, of course, was to look at the blood pressure, which was normal in this scenario. And then we looked at urinary calcium, which was found to be low. So in this scenario of hypokalemic alkalosis with a normal blood pressure and a normal urinary calcium, a possibility of Gitelman syndrome was considered. But when we are really reaching this scenario, we have to think of some other possibilities as well. And we found that he had hypomagnesemia. So again, going more in favor of a Gitelman syndrome. But very importantly in this scenario is that we have to exclude other causes, especially malnutrition, which will by far be the most common cause of this scenario. We found that there was a low fractional excretion of magnesium, suggesting that this was malnutrition. So it's very important that while we are evaluating, we should be clear about what we are dealing with and in which scenario the confusions and problems would be. So we have to look at all the possibilities, and we'll try to cover these cases today to highlight how to approach specifically in that regard. So a proper evaluation becomes very important. All of you can go and have a look at our website, which has got a lot of information as well as courses related to pediatric endocrinology. We have got multiple grand rounds along with postgraduate lecture series, which happens frequently, publications and mobile applications to make life easier in terms of pediatric endocrinology. So when we talk about potassium, it essentially is a balance between 3 sites in which the potassium is affected. We, of course, have the intracellular area, wherein the potassium is largely an intracellular ion. So it is within the cells and exchange with the plasma. Second, of course, is the intestine. So how much potassium we take. But remember the amount of potassium which is there in every food, because it's an intracellular ion, you will never become deficient unless somebody is on a totally parenteral nutrition. The most important regulator of serum potassium level is the excretion of potassium. And this whole axis is largely regulated by the renin, angiotensin, aldosterone system. So for anybody to have chronic hypokalemia, you need to have excess amount of the renin, angiotensin, aldosterone system. Like when you have chronic hyponatremia, your vasopressin has to be high. Similarly, for your potassium to be consistently low, you need to have more urinary excretion, and that is often linked with a high level of aldosterone or a high level of the renin, angiotensin, aldosterone axis. Now, we all know that there is a largely intracellular distribution of potassium. So the concentration of potassium is 40 times more within the cell, and 99% of our potassium is actually in the cell. So extracellular potassium may not be a good reflection of total body potassium. The classical example is in the setting of hypokalemic paralysis, where all your potassium goes into the cells, or diabetic ketoacidosis, where potassium has come out from the cells and your potassium is falsely high. Now, sodium is the opposite. There is a 14-time gradient between the sodium inside and outside the cell. And to maintain that, we have got a large energy-intense process of sodium-potassium ATPase, which really regulates this process. And a large amount of our energy is actually spent in this sodium-potassium pump. Now, this is triggered via insulin and beta agonists. So conditions in which you give more insulin or you give beta agonists, your potassium will become less. in that regard. There are two major other intracellular ions, magnesium and phosphorus. And as a rule, deficiency of one of them will cause deficiency of the other two. So if you have hypomagnesemia, you will have hypokalemia along with hypophosphatemia, along with metabolic alkalosis and hypocalcemia. So this is a very, very classical example of how single ion deficiency can have multiple products. And this is what we're going to discuss about also in one of our cases. As well as in the first case, if we saw, because of magnesium deficiency, you had all those problems which were happening. So hypokalemic alkalosis, hypophosphatemia, hypocalcemia, as well as a slightly lowish level of PTH will suggest a hypomagnesemia being an important possibility in that regards. Now, since kidneys are the major site of potassium homeostasis, we need to understand how kidneys handle potassium. Now, whatever potassium is filtered is all absorbed in the proximal tubule. The only potassium which appears in the urine has to be actively pushed out in the setting of the collecting duct. So basically, the work there is of the epithelial sodium chloride channel, which is basically regulated by the mineralocorticoid receptor. And this ENaC channel basically absorbs sodium along with chloride. The rapidity of movement of sodium is much more as compared to chloride. So there is an electronegative environment in the lumen, and this electronegative environment causes the pushing of potassium. So the potassium excretion is very, very closely linked to the amount of sodium which is delivered in the collecting duct. More the sodium, the body will conserve sodium more, and potassium will be lost in that process. Now, magnesium plays a very important role here. So if you have hypomagnesemia, you will be losing more potassium also from the tubules, and that becomes important. Another important positive ion which is lost is proton, which process is through ammonium production. So all those processes happen in that regards. When your potassium level is less, body would now like to say, okay, I don't want to lose potassium anymore. I want to push off protons. So your ammonium production will become more. So if you have hypokalemia, the natural response to hypokalemia is metabolic alkalosis. Remember, when your potassium becomes more, that potassium inhibits ammonium production. So acid excretion becomes less and you have acidosis. So hyperkalemia begets acidosis, hypokalemia begets alkalosis. So a normal, when you're talking about hypokalemia alkalosis, this is a normal physiological process. Hypokalemia with acidosis is against the tide. That is something you have to understand from that perspective. So now if you have any reason you've taken some diuretics like either thiazide or furosemide, or there is a tubulopathy in which you're losing a lot of sodium, it all will result in a scenario of more delivery of sodium in the collecting duct. So more sodium will be there for exchange, more potassium will be lost. So all these conditions, be it hypokalemic alkalosis, tubulopathy, loop or osmotic diuresis, they will all cause hypokalemia. And as I said, hypokalemia causes alkalosis. Alkalosis causes hypokalemia. So this is a vicious cycle which will keep on going in that regard. So this is something to remember. Now we know that the major regulator of the epithelial sodium chloride channel is aldosterone. The major role of aldosterone is to push the epithelial sodium chloride channel towards the membrane, and it increases the activity of the ENaC channel. So aldosterone is a major pathway which is in turn regulated by the renin system, which is triggered by a high potassium and a volume depletion, which produces renin, which converts it into ANG1, which is converted in the angiotensin receptor ACE enzyme into ANG2, which acts on the adrenals to cause production of aldosterone. So now we know that the renin-angiotensin system is a major regulator of potassium excretion. Now, from a pathophysiological perspective, hyperkalemia, as I said, a major component is 99% is within the cells. So there could be a cellular shift, which can happen with insulin, beta agonist, periodic paralysis, which are the major factors, or you have an extra-renal loss in which your urinary potassium is less, but you're using either via the vomiting or via the diarrhea. So you will have vomiting or NG aspiration, or you have cystic fibrosis in which you are losing through the skin from that regards. Now you can also have a urinary loss in which your urinary potassium will be high. And in this scenario, the problem could either be because of the RAS dependent pathway, which will basically be characterized by a hypertension in that regards. And this we already discussed. This could be a primary hyperaldosteronism, Liddle syndrome, apparent mineralocorticoid excess, CH variants 11, 17. This is not the focus of discussion today. What we are going to discuss more today from that regards is the RAS independent. Now here you can have secondary hyperaldosteronism, but this is not primary. Anybody who has hypovolemia will have secondary hyperaldosteronism, and that itself will trigger the whole hypokalemic alkalosis vicious cycle. So this could be part of tubulopathies. Now tubulopathies could be Barter's or Gitelman syndrome, in which you are losing a lot of sodium as well as chloride, so that would be associated with alkalosis. It could be RTA, which again you're not going to discuss today, which would be acidosis. And finally, you can also have osmotic diuresis or a diuresis also. So diuresis, we said you have more sodium delivery, you will have hypokalemia and alkalosis. So predominantly, I would say three major causes, what we're discussing today, would be the tubulopathies like Barter, Gitelman. Close differential to them will be diuretic. So Barter's is like furosemide excess, and Gitelman is like thiazide excess. This is what you can think of simplistically. Then magnesium deficiency per se, what it can do and how malnutrition can affect will be the other scenario. And of course, diuretic use, as I said, will be a close differential. So we'll be focusing largely about RAS independent urinary loss is what we are looking out in that perspective. Now, I've already mentioned that alkalosis is a major trigger of potassium excretion. We discussed that hypokalemia increases ammonium production, causing proton loss, causing alkalosis. That was one arm. But alkalosis itself will cause hypokalemia. So when you have alkalosis, basically your bicarb becomes more. So your body will push proton from the cells and potassium will go in. So you will have hypokalemia, and this proton will also, bicarb will also be exchanged there in the kidney. So you will lose both in the cell and in the kidney. So therefore, if you have alkalosis, it will be getting hypokalemia, a vicious cycle, as we have discussed, will happen. We discussed earlier that for every 0.1 decrease in pH, the potassium increases by 0.6. That is the response for metabolic acidosis. For alkalosis, it is slightly lower. It is like 0.4. 0.4 millimole decrease for every 0.1 rise in pH is what we need to remember. And this is true for both respiratory as well as metabolic alkalosis. Now, from that perspective, now we'll just touch base about how do we classify hypokalemia. The most important here is, of course, to look at the pH. Now, everybody with hypokalemia should have alkalosis except three conditions: renal tubular acidosis, acetazolamide use, or lower gastrointestinal loss. So alkalosis is not really going to tell you much in that regards. The next step, of course, is to look at volume or blood pressure. So in this scenario, if you are hypovolemic, this is what we're going to discuss today. If you are hypovolemic, you're dealing with losing a lot of sodium, losing a lot of acid. That is why you are having alkalosis. So diuretic, malnutrition, Barter, and Gitelman. These will be the four things which we'll focus today, in which you will have high urinary chloride. You will be losing, that's why you are hypovolemic. Your magnesium may also be low in most of these scenarios. So BP will also be low and normal. So this is the classical scenario we are discussing. If on the other hand, you have a RAS axis, you will have high volume, you will have hypertension, and that's what you will pick up from that perspective. And finally, RTA and diarrhea will have metabolic acidosis. So we're dealing with hypokalemic alkalosis with normo/hypovolemia. So this is what we're talking today. Now, if we go by our approach, we all know that blood gas is a central part to evaluate in the setting of hypokalemia. But before that, you exclude diarrhea, diuretic use, and malnutrition. If there is acidosis, you go more towards the possibility of RTA versus GI loss. You look at urinary anion gap, If you are dealing with alkalosis and your blood pressure is low or normal, you're dealing with malnutrition, Gentleman syndrome, Bartter syndrome. These are the sort of differential, and of course, diuretic use. So that you have to be aware of in that scenario. And this is what we're going to look at. Now, before we start off with the cases, I'll touch base a bit about what we are really looking at in that regards. So from a very simplistic perspective, we can consider that Bartter syndrome is a defect in the sodium-potassium 2-chloride channel. And this is the channel at which furosemide or the loop diuretic acts. Now, because of this, you will have more delivery of sodium in the distal tubule. The delivery of sodium will say, okay, body will say, we are losing a very important thing like sodium. Let's exchange. So it's going to ready to sacrifice potassium, proton, calcium, magnesium in exchange to this sodium. And because of this hypovolemia, your RAS axis also goes up. So your ENaC channel goes up, it starts overdrive. You're losing proton, you're losing chloride, you're losing potassium. So you will have hypochloremic metabolic alkalosis with hypokalemia. So this is what will happen. There will also be an induced AVP resistance because of hypokalemia also, which will cause polyuria and DI-like picture, which will happen. And you will also lose calcium and magnesium. The calcium loss will cause hypercalciuria and nephrocalcinosis. So the most severe form will actually present even before birth with polyamnios, and subsequently there will be a lot of failure to thrive. So this is the classical presentation as far as Bartter syndrome is concerned. And if you look at somebody who's taken furosemide for a long time, like if you talk about a preterm baby who has a hyaline membrane disease, who has got cardiac issues, you're giving furosemide, you do develop nephrocalcinosis, you do develop failure to thrive. So this is exactly a replica of furosemide toxicity. So this is the experimental evidence of nature of how furosemide excess will do on a long term and can be quite detrimental. So you will have hypercalciuria, hypermagnesiuria, you will have hypocalcemia, hypomagnesemia. So everything is low. Calcium, magnesium, phosphorus, potassium, pH, everything is going on that direction in that regards. Now, just to keep it a more nuanced look, because we'll be talking about a specific form of Bartter syndrome today, so we'll dig a bit deeper about how this tubular area works in terms of absorption. So essentially, you've got the sodium-potassium 2-chloride channel, which takes, so this is like carrying sodium chloride and potassium from the lumen to the tubular cell. And from there, you have got the sodium-potassium ATPase, which allows exchange of potassium. So this essentially means you are absorbing sodium while you are exchanging with the potassium from that regards. Now, this potassium is thus pushed out via the ROMC process into the lumen in that regards. And this chloride is then pushed off also via specific chloride channels, ClCkA and ClCkB. So the net effect of sodium-potassium 2-CC, sodium-potassium ATPase, chloride channel and ROMC is that you're taking in salt, sodium chloride, and you're losing potassium. This is what you are exchanging between circulation and the lumen. You're taking in salt and you're losing potassium. This is what basically this whole pathway is doing from that regards, and this creates an electrical gradient. Now, because of this electrical gradient, there will be absorption of calcium and magnesium. They will be taken in through the paracellular pathway because of this gradient from that perspective, and you are absorbing that. So this is a normal scenario. So now in situations wherein you have got more amount of calcium, or if the whole process is affected, so if your calcium sensing receptor becomes hyperactive, a specific compound like HETE, which is a prostaglandin derivative, will start to disrupt the ROMC pathway, and this will result in disruption of the sodium-potassium ATPase, and this ultimately will result in a scenario where all the gradient is lost, and you will be losing potassium, you will be losing calcium, you will be losing magnesium, and the whole process becomes abnormal. So you now have multiple places where you will have manifestations like Bartter syndrome, or you can say phenocopies or variants of Bartter syndrome. So the most severe form is the sodium-potassium 2-CC, which is the type 1. severe form. The ROMC defect will also have a severe form, which will basically have a problem in terms of electrical gradient, and you will be losing again from that perspective. We know that there are abnormalities in the CLCKB and CLCK1, which have type 3 and type 4 RTA. We'll be specifically talking about one of those defects today. And of course, if you have calcium sensing receptor mutation, which is activating, it will cause hypocalcemia, hypercalciuria, and the whole, this is the mechanism how it is causing. So again, that's the type 5 Bartter. So essentially, Bartter syndrome is not a single disorder. There are multiple genes which may be affected. Common to them is the loss of potassium, loss of chloride, calcium, and magnesium. So hypokalemic alkalosis, hypercalciuria, hypermagnesiuria is a basic factor which will be there in that regard. So if you just compare, type 1 is the sodium potassium 2 chloride, most severe form, and you have an antenatal form. The type 2 also is very severe in that regard. This is the potassium. So effectively, if the potassium doesn't go, or sodium potassium, your whole pathway is disrupted. So you will not be losing in that regards. Type 3 and type 4 are milder forms, and they may cause hypercalciuria and deafness. And finally, type 5 with a calcium sensing receptor, and we know it more in terms of hypercalciuric hypocalcemia, the form of hypoparathyroidism that we have discussed earlier. What about Gitelman syndrome? So Gitelman syndrome basically is a defect of the thiazide area where thiazide acts as the sodium chloride symporter, in which you're losing sodium, and because of this loss of sodium, it will be reabsorbed, and you will then be having an exchange which will happen, and you will be losing again potassium, chloride, and proton. You will have hypokalemia, hypochloremia, metabolic alkalosis, and very importantly, magnesium loss becomes much more. Importantly, here the mechanism does not cause hypercalciuria. It's a hypocalciuric variant. So in a child who has hypokalemic alkalosis, you have to look at the magnesium level and the calcium excretion. You will know whether it's more likely to be Bartter versus Gitelman. So low magnesium, high urinary magnesium there. So to compare between Bartter and Gitelman, Bartter is a much more severe problem, especially the severe defects. Both of them will have hypokalemic alkalosis. Bartters may present even in the newborn period, as discussed. Blood pressure is usually normal in Gitelman because the loss, it's not that severe defect, so to speak. Serum calcium tends to be low in Bartters, while urinary calcium is high in that regards, and magnesium tends to be lower more in Gitelman. So Bartters will present very early, failure to thrive, polyuria, hypokalemia. Gitelman will present later on with cramps, with muscle pain, adolescent. That is the usual presentation which will be there from that regards. And of course, polyuria will be there. So now, if we focus specifically on our scenario of alkalosis with normal blood pressure, the first thing is to exclude simple things like vomiting, NG aspiration, and diuretics. Then your urinary calcium, magnesium, and urinary magnesium will give you the trick. In Bartter syndrome, you will have hypercalciuria. In Gitelman syndrome, your magnesium excretion will be more. But if it is a primary hypomagnesemia, your magnesium excretion will be less.